Hello and welcome. We've got 400 participants who've joined us tonight for the webinar on suicide prevention and safety planning in the veteran community. I'd like to also welcome the viewers watching the podcast. How are you all? I hope everyone's well tonight. I'd like to begin by acknowledging the traditional owners of the land on which our webinar presenters and participants are located. I'd like to pay my respects to elders past and present. And I'd also like to acknowledge the communities that have been struggling with bushfires this week and acknowledge the suffering and stress that's been experienced. My name's Glenn Melvin. I'm a facilitator of the webinar tonight. I'm an associate professor at Deakin University in the School of Psychology and a practicing clinical psychologist. For the last 5 years or so, I've been working with colleagues at Beyond Blue on a safety planning application called Beyond Now, which we'll talk about a little bit later. But it's my real pleasure to introduce our panellists tonight. I'm delighted to introduce a colleague of mine, Professor Barbara Stanley from the Department of Psychiatry at Columbia University in New York. Now, unfortunately, Barbara wasn't able to join us in the studio today, but she's been very kind to get up in the middle of the night. It's 3:15 or 3:20 in the morning in New York. So we're delighted to have Barbara with us, and Barbara really is a leading authority in suicide prevention. And if we're lucky, we might even see her puppy Ginger coming to the screen as well. So thank you, Barbara, for joining us. And it's wonderful also to have Jenny Furman, Dr. Jenny Furman, in the studio here with us. Jenny's the Chief Health Officer and Principal Medical Advisor for the Department of Veteran Affairs. As well as that, Dr. Furman's a veteran, a reservist, and a practicing GP. She wears many hats. And Jenny's held many senior positions in health within the military and government in Australia. Okay. So as many of you will be aware, this webinar is part of a series that Department of Veteran Affairs have commissioned the Mental Health Practitioners Network to plan and produce a series of 15. And tonight, the 14th in this series, is, of course, on suicide prevention, and really aiming within this series to develop the capacity of the mental health workforce to be able to support veterans. Some more orientation to the webinar today. We have here some sort of instructions many of you will be familiar with, but just like to point out a couple of things because the platform has been updated. There's a purple box there, or icon, I should say, that can open up the chat box, which I understand many of you are already using. And then the blue arrow is where you can access all the resources, the biographies and the slides and supporting resources. Perhaps before we get to the learning outcomes, I'd like to acknowledge that by registering, you've really agreed to the ground rules for the webinar, which can be found in the resources. And also the format tonight is going to be a bit conversational. We've got a couple of short presentations and then a chance for the panel to chat about some of the issues. And we've also got a brief video to show you a demonstration of the Beyond Now suicide prevention safety planning app. So we'll have that for you a little bit later on, and we'll be discussing the resources and things you might be able to access to support your work in suicide prevention with the veteran community. Now, to the learning outcomes, and some of you might have had a look over these already, but really we're looking through this webinar and also thinking about the pre-readings to increase knowledge about current US and Australian research and how it really informs suicide prevention initiatives. Also looking for attendees to be able to recognise and respond to risk indicators and warning signs, protective factors for suicide in the veteran community, and we'll be having a good look at that. And then moving on to look at increasing your understanding of how safety planning can be used to support veterans who are at risk of suicide and have experienced ideation and may even have attempted suicide. So I want you to be updated about some of the tools and resources that are available to assist with safety planning in the veteran community. So there's next some instructions on the chat box there and how to go about sort of using that. I guess we're here for sort of professional communication, but really want to acknowledge that we're talking about a sensitive topic tonight in suicide, and I imagine it's one that's touched many of you professionally and also some of you personally. So I just want to reach out and say that if any of you are feeling the need for support tonight, to reach out to your support networks, and also the Beyond Blue's support service phone number is on screen there, or follow up with your GP or local mental health service there. So that's our introductions and where we're going to tonight. I'd now like to hand over to Jenny, who's going to tell us about some work that's been done to describe veteran suicide in Australia. There you are.
Thanks very much, Glenn. So up until recently, DVA didn't have a complete picture of suicides in Australia, and in 2016 and 17 they worked with the Australian Institute of Health and Welfare and the Department of Defence to improve our understanding of the incidence of suicide in serving and ex-serving ADF communities. The research is statistically valid, and it involved linking information from the ADF personnel management system with the National Death Index, and that linkage meant we were able to identify much more clearly exactly how many people was suiciding in the ADF and in ex-serving members. And as you can see, there was 373 suicides, 53% in ex-serving personnel. And when we looked at that age-adjusted rate of suicide, it's 51% lower for current serving men and 47% lower for those in the reserves, but higher for ex-serving men. In 2014-16, ex-serving men aged under 30 had a suicide rate 2.2 times that of the Australian men of the same age. So who are the vulnerable veterans? We note that there's no significant differences between the single services, Army, Navy and Air Force, or those who've deployed or worked on humanitarian operations, or those who've never deployed. And we know that most people, when they leave the ADF, they're well with no problems. However, there's over 200 different risk factors that can come into play, and it's important as clinicians that we work with the whole person to try and identify what are the particular risks for them, and those risks might change with time as well. So it's important to understand that. But when we looked at the data that came from the AHW, we could see that men aged 18 to 29 who've been discharged involuntarily, and that particularly is the case if they were medically discharged, and if they left the ADF with less than 1 year of service, so a short period of service, or held a rank other than commissioned officer at discharge. Risk factors that can be seen and particularly relevant to this population is social isolation, if they have little or no support networks, such as a significant other, family, friends, etc. If they've been involved in legal or disciplinary problems, and that could even include compensation and any legal processes. If they have impulsive or aggressive tendencies, problematic anger, or are undergoing a relationship breakup. So in addition to the work with the AIHW, Defence and DVA commissioned the Transition and Wellbeing Research Program. This is the most comprehensive study undertaken in Australia to examine the impact of military service on mental, physical and social health of serving and ex-serving ADF members. It was conducted in 2015, so that was the year in which the survey was taken. It involved partnerships with DVA and the Department of Defence and researchers from the Universities of Adelaide, Monash University, New South Wales, Sydney University, Phoenix Australia Centre for Post-Traumatic Mental Health, and the Australian Institute of Family Studies. And this provided a wealth of data on suicidality and mental health in individuals who transitioned from the ADF service between 2010 and 2014. So in this study, transition meant that people who had left full-time service and were either in the reserves or had left altogether and no longer served in any capacity. So what did this research show us? Well, it showed us that 46.4% of transitioned ADF members are estimated to have experienced a mental disorder in the previous 12 months, which seems pretty high. Half of the transition members remained in the ADF as reservists, so many were still in the reserve, and 43% of these people had reported accessing DVA-funded supported treatment, and over 1/5 of the transitioned ADF were estimated to have been medically discharged. So in this group, we've got a quite large number of people who've been medically discharged. The good news was that 84% of those who transitioned were either working or engaged in some purposeful activity. But if we looked at suicidal ideation and attempts, 21.7% of the transition ADF reported some form of suicidal ideation, plans or attempts in the last 12 months, and more than a quarter reported their life was not worth living, and an estimated 21% reported they felt so low that they thought about death by suicide. Overall, almost 8% of the transitioned ADF reported making a suicide plan, and 2% had attempted suicide. When we look into this data even more carefully, we looked at what was some of the risks for increased suicidality, and it's similar. It's those who served in the ADF for less than 4 years, had been medically discharged, were a client of DVA, had been in the army, and were of a lower rank when they were serving. And if you think about that, the same sorts of themes are coming through. So what do we need to be aware of in terms of risk factors? Suicide prevention requires a multi-layered approach, and what I'm going to look at is what sort of things do you need to be aware of when you're looking at what sort of risk factors exist for veterans. From the Transition and Wellbeing Research Program, we know that veterans in serving ADF are most likely to seek formal support in the first instance from their GPs, medical officers and psychologists. And while lots of people seek support, we need to improve the number who stay in that care and are receiving evidence-based care. We know we need to do a comprehensive assessment. There's over 200 risk factors, as I said, and it's important to work with the whole person and understand all the risk factors for that person. Transition and military service can both be challenging, and there are some protective factors. But on transition, veterans face a number of stressors. For instance, their military skills might seem less relevant, and they might experience difficulty in translating those skills to a civilian context. They might lose self-esteem as a result. They might struggle to find meaningful work. When they do find work, they might find a really quite different workplace culture to the one they've known. They often have to learn new skills. That can include accessing healthcare, renting, finding accommodation, and they may have lost touch with their family and childhood friends because the ADF requires them to move a lot, and they might just over time have lost contact. All these things often lead to stress in the family, and we know from working on the ground and from the research that relationship breakdown is a risk factor in this group. But we know that from this research that while for some individuals there are protective factors associated with being with an ADF member, and remember the rates of suicide in serving members is half that of the Australian population, we still know that suicidal ideation and planning for those who have transitioned is high, and it increases after they've transitioned out completely. And again, the message is it's higher for younger males of lower ranks and those who've been medically discharged. So what are the protective factors? Well, as I said, we've got a significantly lower all-cause mortality in full-time and serving reserve populations compared with Australian men, and that's really partly a healthy soldier effect. They're generally selected to be healthier, and we have lower suicide rates while people are in, but then that increases after they leave. So what are some of those protective factors? They're things that help someone deal with their life better. People in the ADF and serving members are well trained. That gives them a good feeling of self-esteem. They work in an organisation with a common purpose. They're taught problem-solving skills and how to manage in high-stress situations in the military context. And their culture, it really emphasises support for the team, support for each other, and as I said, they're generally healthy. So it's good to understand those protective risk factors when you're seeing someone who might be having some of this suicidal ideation and thoughts, because reminding them of their strengths is a really important way of giving them hope and helping them think that they'll be able to improve. They also know that we also can remind them that increasing connections with family and friends and their community is really important in the longer term and will help them with an increased sense of belonging. So here's some of those protective risk factors, and you can see from this list that many of those are things that people in the ADF would already have, and it comes up as part of their service. They don't have a particular religious faith or religion. If you think that ADF culture is a religion, perhaps you do. They definitely have a cultural identity, norms and values. As I said, they're good at problem solving. They've got good self-esteem. They often are very fit and well. And so all those things are the protective factors. So when you see someone, really understand what are their protective factors, what perhaps of those protective factors have been eroded over time, and what additional risk factors might come up in the transition period in particular. Back to you, Glenn.
All right. Thanks very much, Jenny, for a very well-rounded presentation. I like how you balance the risks and the strengths that come with military service. I think that's been very informative for our audience. One of the risk factors that we sometimes sort of hear about is the role of trauma in the Defence Force and the link to suicide there. I was wondering if you could just speak a little bit about that, what your thoughts are.
And well, as I've said, people in the ADF are well trained.
Yes.
They are able to deal with high stress situations. And that's important because, in fact, the ADF does often place them in high-stress situations where they may be exposed to trauma. And that can include on operations, but it can include humanitarian work, disaster relief. So, yes, they are exposed. At times that can lead to mental health issues and problems, but it doesn't necessarily lead to suicidal ideation. Yes. If you think about it, the rate still remains low in the ADF, and it's that transition period where it's a problem. When we look at the data, there doesn't seem to be any difference between different services and the type of service or exposure to operational service and trauma.
Thank you. And what would you say from the research that's been done in Australia would be the key sort of take-home messages for practitioners from these studies? What would you like to sort of pull out there?
Look, I think the key message to me is to understand what are all those protective factors and risk factors, to understand that some groups, particularly men under 30 who've served less than 5 years, who are leaving not of their own volition, perhaps they're being medically discharged or administratively discharged, are going to be at increased risk. But also the key message, I think, is to look at the person as a whole and understand what else in their life might be increasing their risk, and also think to reassess that risk over time. Over time,
yeah, that's a very important message. Suicide risk assessment isn't done once.
Exactly.
It's something we need to keep updated over time, isn't it? Very good. Okay, well, I think at this point we'll hand over to Barbara. Still awake there, Barbara?
Yeah.
I'm sure you are. I'd like to hand over to you now to talk about safety planning intervention and where that fits for people who may be at risk of suicide. Thank you, Barbara.
Sure. Thank you for inviting me to join you. I'm very happy to be on this presentation tonight. So what I'd like to do, though, is before I start talking about the actual safety planning intervention, I really think that it's very important to put it into context. And so I have up here something that I like to call the suicide prevention wheel. And And this really just identifies all the aspects of suicide prevention, from population-based interventions to what Jenny actually just talked about, which is screening and identification. And so we can't do an intervention unless we have screening and identification first. And then we have to understand, okay, so what are the other things that we can do to help suicidal people? And so what I'm going to be focusing on is this one piece of the suicide prevention wheel, which falls under brief interventions. And the brief intervention that I'm going to be speaking about is called the safety planning interventions. But it comes in the context of there are other kinds of brief interventions out there. In addition, we have to remember that there are other strategies that we can use to help, and we have to use to help prevent suicide. That includes going to the emergency room, psychiatric hospitalizations, and then suicide-specific interventions that are like longer-term psychotherapies, and then also medical therapies. There's medications. There's a lot of work being done now with ketamine, brain stimulation, and so forth. And so the reason that I stress this is because safety planning is a really good intervention, but it's one piece of this suicide prevention process. So if we look at the next slide, it becomes clearer where safety planning fits in. So if we think about, there are two kinds of risk in suicide. There's kind of a more elevated, more chronic risk that lasts, if you look at the x-axis there, that lasts weeks and months. And that's where the more suicide-specific medications and psychotherapies come into play, as opposed to a brief intervention. And so there are things that Jenny spoke about a bit. So things like depression, substance use disorder, very severe persistent stressors, and kind of psychological factors like chronic hopelessness. And this is where we use those kind of more longer term interventions. So if you look at the next slide, though, this is where a brief intervention like safety planning comes in. And so you could, in a person that has a kind of a more chronic elevated risk that lasts weeks or months, what happens when somebody is suicidal is what gets layered on top of that is these acute crises. And so you can see on the x-axis here, we're not talking about weeks and months, we're talking about minutes and hours. And so somebody is at a kind of a chronic elevated risk. They're in the midst of a depression, or they're in the midst of having severe psychosocial stressors. And they may have chronic suicidal ideation or chronic thoughts. And then something happens where they flip from feeling this down, depressed, having these stressors, into a very acute crisis state. And this is where a brief intervention like safety planning comes into play. And so you can see this is what we call the suicide risk curve. And so what we help people do is learn that there is such a thing as this suicide risk curve. And you can see that the risk elevates. For some people, it elevates gradually, or other people, it goes really, really quickly, like a matter of minutes between feeling suicidal and then actually engaging in the behavior. And so what we work with them on in doing a brief intervention is to identify what are the warning signs that indicates that they are going into this acute risk state. And that's where we help them learn to pull out their safety plan and use it, or get on their app and use the safety plan, so that they don't reach the top of that risk curve where they act on their suicidal feelings. And one of the things that's really important to remember, and when I work with people on this, we talk with them about this. So we do a bit of psychoeducation with them, where we will say, look, if you don't act on your suicidal feelings when they are feeling so strong in that acute risk phase, the risk eventually comes down. It isn't like you stay in that chronic risk state. And so the way that I think about this is that time is a suicidal person's friend, where the risk will dissipate, the risk of acting on the suicidal feelings in that acute crisis phase dissipates over time. And so what we want to do is to help people get through that risk phase, that acute crisis. And so that's where a brief intervention like safety planning comes in and is helpful. And so if you think about, you have this kind of chronic elevated risk that hopefully people are addressing, and then you layer on top of that an occasional a suicidal crisis. So the person should be getting help for that chronic risk, and then as they are getting help for that chronic risk, we have an intervention like safety planning that can be used to help get them through the risk state. So what I'm describing is what I see as ideal in terms of helping suicidal people. In reality, often what happens is what individuals have is simply a brief intervention like safety planning. They don't have help with underlying conditions. So if we look at the next slide, we can think about the targets of suicide prevention interventions. And so we look at this as three different phases. So the first is acute risk interventions or crisis interventions like safety planning. And then, as I mentioned, the more chronic longer-term risk interventions like longer-term psychotherapy. And then finally, you want to think about what Jenny talked about, which are some of the protective factors. And while a person brings to a risk state their own protective factors that they carry with them, you can also build protective factors. And so you can work on helping build emotional reserve and resilience. And so these three things have an interplay with each other. So now I'm going to turn to just talking about the safety planning intervention and why we think that it's so useful. So on the next slide, you see a slide that I took a picture of from a plane, and this is the plane safety measures. So when we go on an airplane, every single time we get on the plane, we go through what are the safety measures that we should use should there be difficulty on the plane. In particular, there's a focus on, should the cabin pressure drop, what do we do? If there's going to be a crash landing, where is the life vest, and so forth. And we do this every single time. And so why do we do this? And this is why we put together an intervention like safety planning for suicidal people. When we are in a state of emergency, which is what an acute suicidal crisis is, or an acute crisis would be when the cabin pressure drops on an airplane, we're not thinking clearly. We can't think clearly. So we have to have strategies that we know are in place prior to the crisis. And hopefully they're practice strategies, or they're strategies that are at least immediately available to us. So on a plane, if you've been on a plane several times, you know, if you're traveling with a young person, what do you do when the cabin pressure drops? Do you put the oxygen mask on yourself first, or your little child? Everybody knows from having heard this over and over, you first put it on yourself and then you put it on the child. And so that's kind of the way that we think about safety planning. We want to know, we want suicidal people to not have to generate solutions and strategies of how to cope when they are in acute crisis, because they're not going to be able to. And so on the next slide, you'll see an example of the form that we've developed. It's not as detailed and as elegant as the plain safety measures, but this is what the intervention, when you look at the form, looks like. And it's called the Safety Planning Intervention, or SPI, and it was developed by a colleague, Greg Brown, and I. We first developed it in the context of working with suicidal adolescents. And now it's been used all over the world, and including being adapted into app form in Australia. So what is this intervention? So it starts with people identifying what their warning signs are. So when is there a crisis? When has the equivalent of the cabin pressure dropped and it's an emergency? And so in order to use an intervention, you have to know you need it. And so the oxygen masks drop only when the cabin pressure drops. And so we need to help people identify what their warning signs are. And so once they know that they are in a crisis, we have developed this intervention that has a series of steps. And I'll come back to that in a minute. So the way that we have recommended doing this, and people seem to actually like it because they don't have to think about it, but it's a structured plan, and you just walk through it step by step, and you keep using the strategies that we identify here until the crisis subsides. And so as you go through the plan, it moves up to higher and higher levels of external intervention. And so you start with things that you can do by yourself, and all the way up to going to the hospital. So in the next slide, this is one of my favorite books called The Tipping Point by Malcolm Gladwell. And the thing that I point out here is that the subtitle, which is how little things can make a difference, a big difference. And that's how I think about safety planning. It is a little thing, it's a small intervention, and yet we get pretty strong results, which I'll talk about a little bit later, in terms of helping prevent suicide. And the way I guess I have always thought about this is we shouldn't be asking a little intervention like this to be working by itself to prevent suicide. We should be thinking about it in the context of several suicide prevention interventions. But we have done research and found, in fact, this alone does end up making a difference. So it is a little thing that can make a big difference. In other words, it can save a life. So if we look at the next slide, you'll see we developed this intervention based on several different strategies. Looking at brief problem solving and coping skills. So what we want to do in a brief intervention is just take what are the simple coping skills that you can identify, know them in advance, and use them. Safety planning engages the use of distraction. And so this may sound a little funny that we're having somebody distract themselves while they're in a suicidal crisis. But in fact, if you remember back when I talked about that the acute suicidal crisis only lasts a little bit of time. If you can kind of, and it just clicks on as time passes and the risk subsides. If you are taking yourself away from your suicidal thoughts, even for a little bit of time, you are allowing time to pass in the hopes that the suicidal crisis goes away. And so even if we don't do anything during a suicidal crisis, which is that small space of time, it goes away by itself over time. People do not remain acutely suicidal chronically. So we have people identify what their individual coping skills are. It helps enhance their social support. So who can they reach out to? It's really important to know who your emergency contact should be. And then a couple other things that is particularly important in the United States are means counseling or means safety. And that is, how do you limit your access to whatever kind of lethal means you would think about using? And I mentioned in the United States because we have a lot of access to firearms here. And of course, firearms are very deadly. If somebody tries to kill themselves with a firearm, over 90% of people die. And so it's an extraordinarily lethal means, as opposed to people who attempt to kill themselves using pills. But whatever means somebody considers, what we should talk with them about is how to make their environment safer. Because if you think about that this acute suicidal risk state only lasts a little while, we want to put as much distance between us, the suicidal person, and the means that we have. And so the more difficult we make it for ourselves to have access to the means, the more likely it is that we're going to get through that risk state safely. And then finally, we will do reasons for living, which some people find extremely helpful while they are in an acute suicidal crisis, to help them not act. Like, what are the reasons that they have that they want to stay alive for? And so this is things like having children. It's many things. So I remember I worked with a young woman, teenager, and one of the things that she had a major desire to be when she grew up was to become a hairdresser. And so one of her reasons for living was to see the day when she became a successful hairdresser. And so for her to think about that and have that in her mind was really helpful. Okay, just a couple other things. So if we're thinking about doing this intervention with the clinician and the suicidal individual one-on-one, it's really important to think about the way that we approach this as partners. we're two people together working on this strategy together. So it's not me as an expert clinician telling the suicidal person what to do or how to approach things, and it's not the suicidal person struggling on their own to come up with all of these strategies. We're sitting together, working together, and coming up with solutions. And as I said, we do psychoed with this. We explain how suicidal crises come and go, because if you say to somebody, okay, you have, I see that you've made a suicide attempt, or that you had to go to the emergency room because you were afraid of acting on your suicidal feelings. I have an intervention here so that you don't do it again. Here's a safety plan. It really doesn't put it in context for them. And so we need to explain to people how suicidal crises come and go. I show them that suicide risk curve that I showed you. And then I explain to them how something like a safety plan helps prevent acting on those feelings. And then we explain how the safety plan should be used and how it creates a sense of self-control. And so then if we have time, and we're doing this in person as a kind of a one-on-one intervention, we have them tell how they got to making a suicide attempt, like what led up to it, not the 10 years before, but in that small space of time, those minutes or hours where the acute risk became very strong and elevated, so that we can help them identify what their warning signs are. So in the next slide, I talk about the suicidal crisis narrative, and that is simply just what I said. We have them just tell the story, basically, of their suicidal crisis. And on the next slide, it shows the suicide risk curve with an individual's suicidal crisis on the curve. And so for this particular person, so this is an actual person, the person, his crisis started during the day while he was at work. So now this comes in the context of somebody who had an elevated risk. This didn't come out of nowhere, but he hadn't made a suicide attempt and hadn't had an acute suicidal crisis, except for this day. So at work, his supervisor was very critical of him, and he started thinking everything is falling apart. And there were a lot of reasons that he was thinking this. So he left work, he went and he had some beer at the local pub. Then he went home and he started arguing with his wife. And he said to himself, you know what, I cannot take it anymore. And so you could see the crisis is escalating. I'm simply helpless. And then he had the thought, maybe it would be easier if I just ended it. And so he got out his gun and he put it to his chin, but he didn't pull the trigger. And just as he was about to, he got a phone call on his cell phone, and his friend, it was a good friend of his, and it interrupted him. And his friend could tell something was wrong, and his friend asked him, "What's wrong? What's wrong?" And so he told his friend that he was suicidal. He told him what he was doing, that he had his gun out. His friend came over and took him to the emergency room. And so you can see here that even at the point where he was ready to pull the trigger, there was something that where it wasn't 100% that he wanted to kill himself, because if it was 100%, he wouldn't have stopped and answered the phone. And so his friend took him to the emergency room, and as he sat in the emergency room, he began to have the feeling of like, I don't really want to die. I just don't want to be in this pain anymore. And so you can see that, okay, so it's a matter of, for him, it was a matter of hours where the suicidal crisis resolved. And which he had been reluctant to do before, he became willing to engage in mental health care. And so we try to walk through this and do this for every single person, especially going up to the point of where they made the suicide attempt. But we then we may not be able to identify all these points after the suicidal crisis, but we do make sure that they understand that, the crisis subsides. A lot of times we'll do this with people who come to the emergency room before they actually made a suicide attempt. And so they already know that once they're in the emergency room, for the most part, their suicidal crisis has subsided. And so we just really want to point out that, look, if you get through this space of time, you're not going to be acutely suicidal, at least for another period of time. Okay. So just to give you an overview of the steps of the safety plan on the next slide. And the app is very similar, and Glenn is going to demonstrate that in a couple minutes. So we start out with recognizing warning signs, and then we help them identify what are things that they can do by themselves. We call it internal coping strategies. It's really just really simple things that people can figure out by themselves. This is not rocket science, but it ends up being extremely powerful. And so it's just small things that they can do that take their mind off their problems just for a little while, just takes them outside themselves for a little while. And so for young men and boys, it's, if you think about the state of mind that they get in when they play video games, that's what we want people to try to think about. What for them makes the passage of time go without even noticing that time has passed. So we want to try to have them identify what are things that they can do by themselves, because often people get suicidal in the middle of the night. What are things they can do by themselves without contacting anybody else that are strong distractors? For a lot of young women, it's playing with their pets or watching cartoons, kind of like these like animated cartoon shows on television. And so we try to be really specific with people, and we write them all down. And then so we identify a few of those things. If that doesn't work, we have them identify what are people and social settings, social places that they can go to that also serve as distractors. This is not saying, okay, I'm going to tell this person that I'm feeling suicidal. It's, again, the same kind of way as our activity that we're doing by ourselves. What is a person that you could talk to that is a good distractor for you, or a social place like your local coffee shop, something like that. And then we, if that doesn't work, we have them identify family members or friends that they could go to and say that they're in a crisis. So you notice it isn't, go to the hospital right away or call your doctor right away. We encourage people to begin to try to develop strategies to cope by themselves and encourage kind of coping by themselves, because if we say to people, in the States, we often say everybody has on their phone, if you are suicidal, not everybody, but I'm sorry, clinicians who have practices will have on their telephones, if you are suicidal, go to the nearest emergency room or call emergency services. almost nobody does that. And so we want to expand the array of things people can do if they are suicidal. So we identify people who are in their natural circle of social support, who they feel like they can turn to. And then finally, we have them identify where's your nearest hospital, what's the crisis hotline or the text line, and if they have a mental health professional, who that person is and how to get in touch with them. And then lastly, besides talking a little bit about reasons for living, we go through how do you make the environment safe for you? And so that step is, okay, you took an overdose. When you go home, can you work with somebody to get rid of all unnecessary medication? People usually have lots of pills around the house. And so can you get rid of all those extra pills, just keep what you absolutely need, small amounts of it in the house. So you want to kind of put a buffer around the person. And so some needs are very difficult to talk about restricting access. So a predominant way of dying by suicide is hanging. It's very difficult to remove all of those things. However, people do get, if you really sit down and talk with somebody about it, people do get creative about it. So I've worked with people who, one of the things that they think about is going, jumping off a bridge. And so one of the women I worked with had to walk over a bridge to and from work, whether she was in an acute suicidal state or not. And so her strategy was, okay, I do have to go to work, but I'm not going to walk over that bridge when I'm alone. I'm either going to have a companion walking with me, or I'm going to wait till somebody else walks across the bridge. And so it's not perfect, but you can see that you can think of things, even something difficult like that. And then the last thing that I'll talk about here, I just want to put up for you what a completed form looks like. And so I'm just going to go through the first couple steps because you can see that it's really very, very specific. So one of the things, a warning sign for this person is, and this is actually a really good one, thinking I have nothing to live for. The other ones are specific, but they're a little more diffuse. They're maybe like at the very beginning of the crisis. And then if you look for this woman, what she said was, what are her coping strategies that she can do by herself is look at pictures of my son, lift weights at the gym, or watch a game on television like baseball or football. So it's specific. It isn't just turn on the TV. It's what kind of television program you should turn on. And so the whole thing is really specific. And interestingly, this person thought about killing themselves by getting into an auto accident. And so the strategy was, when feeling acutely suicidal, don't get into a car and drive. So I think I will stop there for now and turn it back over to Glenn and Jenny, and we'll have the opportunity to have questions later.
Mm-hmm. Well, Barbara, I just might ask you one question at this point. I know you've done a lot of research with veterans and safety planning. Could you speak perhaps briefly about veterans' reactions to safety planning in the work that you've done?
Yeah, sure. So we did a fairly large study in veterans. And in addition to just looking at outcomes, we interviewed them several months afterwards to get their reactions to it. And to find out, what did you think about this? Did you remember you did this intervention? What was useful about it? What wasn't useful? And I can't tell you the number of times that veterans said the following to us. This intervention saved my life. And to me, it was very, very surprising. It's one small little piece of paper, but we heard that, and we continue to hear it so many times, that for some reason, having this is incredibly helpful. And so one person told the story of keeping the intervention in his pocket and going. And that's what he just did, because he often entered acute suicidal states. Having gone to a bridge, not thinking about the safety planning, but having gone to the bridge, being in an acute suicidal state, was going to jump, and then touched his pockets, felt that he had the safety plan in it, remembered that he did it, pulled it out, looked at it, walked off the bridge. And so the kind of reaction is that people have said, look, this is what it does for me. I don't have to white knuckle a suicidal crisis anymore. So people understand that these are like time limited crises, that they just kind of like white knuckled it, held on through it until the risk dissipated. And so the safety plan gives them the opportunity to develop a little bit of self-efficacy, and to exert some control over their suicidal state. I don't know if that answers your question.
Yeah, certainly. Thank you, Barbara. I think now we'll have a look at the Beyond Now safety planning app, and so we've to show you this in the most effective way, we've pre-recorded a video that will show you how to use the app. So the app, just to remind you, is a free app. It's available on iPhones and Android phones. And for practitioners thinking of using it, I'd really encourage you to download the app yourselves, have a play around with it, see what the functions do, because that really helps you enormously when showing it to a client or patient. So if we could roll that video now, thank you.
Hello, and in this brief video I'm going to show you how to use Beyond Blue's Beyond Now safety planning app. So when you first download Beyond Now, you'll see a series of onboarding screens that explain the purpose of Beyond Now and provide you with the terms and conditions. But I've skipped over this for today. I'd like to show you a pre-prepared fictional plan. So this is the home screen to Beyond Now, and you'll see a number of features on this screen. In the top right, you'll see a red telephone. If we press that, it takes us through to emergency supports that can be called from within the app. So we can press on emergency services and then are given the option to directly call 000. So we've included emergency services, suicide callback service and lifeline. These are sort of hardwired into the app, but we also can see on this screen contacts that the fictional person who's created this app has entered there. So if we close out of that one and move to the other side of the app there at the top left, we'll see a menu button. So there's a short menu there. And if we go to the settings, we can select a theme from the Indigenous artwork there that I had selected, or we can select the sun coming through the clouds artwork, for want of a better description. Okay, so if we come back to the home screen, at the bottom there we can see some photos that have been entered as a part of this plan. And then in the middle, two options: My Plan, which will show you a copy of the plan, or Edit My Plan. And let's go to Edit My Plan now to take through the steps. So, first step is my warning signs, and here we can enter those warning signs by clicking on the plus sign for add at the bottom, and then select the text option. And we might want to add another one, say drinking too much has been an issue around time of high risk. We can pop that one in. At the bottom there you'll see some other features. We've got steps. We can navigate through to latter steps of the plan if we like. We'll close out of that and stay with where we are. And we've got some arrow keys at the bottom that help us navigate through to the next step. In step number 2 is about making my space safe, and here we've got steps to cleanse the environment. So we've got one entry there: give key to gun safe to brother. And if we're not sure about what else we might want to put in there, we might want to look at suggestions. So if we click on that at the bottom towards the right, we'll bring up some suggestions that we've pre-populated. These are things from the literature found to be helpful, and also contributions from people with lived experience that help develop Beyond Now. So give my medication to someone else to look after. We might want to add that in, but we might also want to personalize that a little bit. So we can just delete some of that standard text. Give medication to your brother. Let's put brother in there. Okay. So if we move on to step number 3 is reasons to live, and here we can see for the first time we've also got the option of adding photos as well as text, and we can do that by clicking on the camera button, and we can take a photo or a video, sort of switch through to the camera and insert it that way, or we can choose from our library of photos stored on the phone. Let's move on though to step number 4 of things I can do by myself, and here we've got internal coping strategies, and there's a number entered there. You can see again we can enter photos to remind us of things we can do, but one of the benefits of having a safety plan on an app is that it's easy to edit. So if you think, oh, we're no longer really interested in cooking, we can delete those out of the app quite easily, and then think about what else we might want to add. Step 5 is people and places I can connect with. Really good distraction sort of technique. Here the other option we have is importing our contacts directly from our address book sort of within the phone. So we can import those in. As you can see, one has been imported there, as well as a suggestion, and also got a photo. In step number 6, we've got people I can talk or yarn to, and this is sort of more like your inner circle of people who are supportive. So we've got here again the option of adding text or contacts or photos. And the last step, step number 7 of professional support. As I mentioned, we have those top 3 there that are pre-entered into the app, and as well in this case a person's added in their doctor. So to keep moving, we press the blue tick in the bottom right corner, and that takes us through to this screen, a little affirmation, well done, and now some instructions what to do. Use the plan whenever you feel unsafe. Keep the plan up to date and make sure the contacts you've got in there, the photos, the strategies are useful ones for you. And then the other feature within Beyond Now I'd like to show you is sharing the plan. And we press the bottom right button there of share. And this takes us through to an email. In this case, we can share also via text and other messaging and communication services. And you'll see here we've got a paragraph or two up front to explain to the person what this email sort of is about, and there's also a link to the Beyond Blue website with further information about safety planning and what the possible role might be of someone who's a support person to someone who experiences suicidal thoughts or urges. And we have here the list of text from the app, and we also have the capacity to edit just in case there's something that the person doesn't want to share with the person who's being emailed, so we can edit that. Let's cancel out of that though now. The other thing we have here is the capacity to review, and this gives us a similar sort of very linear view of the safety plan, and we can dial our contacts from within this view. So this is the final step or final thing I'd like to show you in this quick tour of the Beyond Now app. Thank you.
Well, I hope that video was useful in showing you a little bit about how to use the Beyond Now app. We've been doing some research with the app and getting a lot of very positive feedback. People seem to like having all their plan in one place, so they always have their phone within about a metre of them at all times, so the plan is very accessible. They've also expressed how the plan gives a sense of hope. And to echo Barbara's words, Reasons for Living has been a very popular, we've had a lot of positive feedback about that section. So there's also a sense of connection as the other thing. So having those contacts listed within the app really as providing a containing sort of experience. So I hope that's one that's useful in your work with veterans who may be suicidal. I'd like to hand now to Jenny, who's going to talk to us a little bit about access and uptake of veteran mental health resources and services in Australia. Thank you very much, Jenny.
Thank you. So often people ask, what's DVA doing about this? And we've had a number of inquiries and commissions that have looked into what we can do about suicide prevention for veterans and serving members. And they've come up with some common priority areas. And if you look at them all, they're all pretty straightforward. So how do we improve mental health support? Well, a really important thing that DVA has done is something called non-liability healthcare. And that means that anyone who served even one day in the Australian Defence Force is entitled to free healthcare for mental health problems. Mm-hmm. So that can be from counsellors, might be from their GP, it might be from the psychiatrist, it might be in hospitals, but it's free. And so that's one way of trying to improve access for veterans. We also think we need to improve awareness and resources for people about suicide. And on our website, we've got something called the Operation Life program. That includes a safety planning app, which is pointed at veterans and is more veteran specific. It also includes face-to-face workshops, some online suicide awareness and prevention resources. We also want to understand more about suicide in the veteran community, and the work with the AIHW and the Transition and Wellbeing Research Project has helped with that. Also, we've had some recent trials which have been piloted on the ground at suicide prevention. What can we do practically? In the transition process, we know that's a stressful period for veterans and we'd like to help them. And really, what can the ADF and the Department of Veterans Affairs do together to make that transition process better and less stressful if possible? We're also looking at how do we improve family support, and our counselling service offers free counselling to families. And as well as that, we're looking at how we can transform DVA's systems and processes. We know that claiming for DVA in that transition period is stressful in itself. We'd like to make sure that people can put a claim in quickly, can get access care faster, and for people who have really complex problems, we've got some really, really robust, complex case management teams that help with people who are really having to navigate some of those services. We've also got our own Veterans Counselling Service called Open Arms. It used to be called the Vietnam Veterans Counselling Service, but last year it was rebranded and renamed to Open Arms, and that's really to reflect that younger veterans aren't Vietnam veterans, that Open Arms provides services to a much broader sections of the community. We provide counselling for serving members, for ADF members who've transitioned and no longer serving, to their families, to their children. We do a lot of relationship counselling with Open Arms, and we do some group programs. And one thing that we've instituted recently is some community and peer advisors. That came about through one of the suicide prevention trials, the one in Townsville, and they've become a really important part of our suite of resources. They're lived experience peers who are trained. We give them 6 months of training, and they're able to bridge the difference between veterans who are in the community who might not be accessing healthcare and helping to bring them into care. They also go into hospitals where veterans might have been hospitalised after a suicide attempt, and help them in that post attempt phase when they've discharged from hospital. They help them reconnect in the community, help the community understand what mental health services are available in the community, and have been really a wonderful resource in the Townsville community. So much so that we're rolling out peer advisors nationally so that we can have peer advisors everywhere. Thanks.
Very good to hear about that work with peers. So we have a little bit of time for, I guess, some closing thoughts from our panellists. Barbara, I'd be keen to hear from you, reflecting on your work with veterans and safety planning. What are perhaps one or two key take-homes you'd like the audience to leave with today about their work with veterans?
Well, I guess just to harken back to the Malcolm Gladwell's book cover, which is that, little things can make a big difference. And so a strategy like doing something as simple as safety planning. And it's great to hear about your peer program, because people often love to have, if there is a peer available, to have peers on a plan. But a little thing can make a difference, in that that suicide is preventable. It's not inevitable. And so I guess that would be the most important thing that I would say.
Okay. Thanks very much, Barbara. And Jenny, do you have any closing thoughts or key takeaways, messages that you'd like to share?
Look, I think you've got to remember that veterans and ADF members are very skilled people in the community. Mm-hmm. They've had lots of resources and abilities that they've learnt over time. And whilst they might have left the ADF and are going through some hard times, we can help them to come back from that position. I think the suicide safety planning helps with some of those impulsive thoughts that can happen, and helps control that and help you overcome that particular period. And just reconnecting veterans with their friends, family, community is enormously helpful to them to start to feel part of that community and have better resources to look after themselves into the future.
So that sense of social connection
absolutely
is a really important part. And the other message I got from what you said earlier was about thinking about the whole person as being a really important component to think about when working with a veteran. Perhaps one last point, if we can sneak in. I know as a veteran and a reservist yourself, you have that sort of insight into how things work and so forth. But I'm aware that perhaps a number of our clinicians, practitioners viewing the webinar may not have those sort of insights. Can you share with us perhaps a final point about that perspective? It might be helpful.
And look, one thing I was reflecting earlier before we started is that when I would be seeing patients while I was a serving member in the ADF, there was a relationship between the patient and myself. I'm there to do the best thing I can for that person. And equally, I know that in the time comes, they will do their job in the ADF and do the best thing for me. And we had shared respect for each other in every consultation. In the civilian community, you don't know your patients as well, and you don't have that same equation. But if you can work with a veteran in the community as your patient and get to the point where you can both trust each other in that way, you'll really get a very good outcome, and a veteran that will want to work with you to be as well as they can be.
Wonderful, wonderful. Thanks for sharing those insights. That insider's view, I think, is very, very helpful. So at this point, I'd just like to remind the viewers, the participants in the webinar, that if this has sort of stirred anything up in you, that help is available from Beyond Blue and your local services. Also like to highlight the local networks that Mental Health Professional Network have established. You may be interested in joining up with one of those veteran-focused networks, or even starting your own. And there's some details on the slides there to get in touch with Amanda about this. Okay, don't forget the resources and the resources tab. You can download those and access those resources either now or into the future. And I want to thank you all for participating in your questions and interaction today. And very sincere thanks to Jenny for joining us in the studio here and sharing your experience. I know it's been very valuable to me, and I'm sure it has for the audience. So thank you.
Thank you, Glenn, and thank you, Barbara. I really enjoyed this evening.
Yeah, and Barbara, thank you for getting up in the middle of the night to be with us. Really, I think we've all learned a lot from your experience in developing safety plan and research and clinical expertise. Very grateful, and hope you get a sleep in tomorrow morning.
And thank you for including me. I really appreciate it.
Thank you. Okay, so this was the 14th of 15 webinars, and I really want to alert you to the next one, which is March 15, 2020, on supporting families. I know this is a very sort of important topic. At that point, we'll sign off. Thank you very much for your participation. I hope this has been valuable. Hope you've all picked up at least one or two clinical points, or for some of you, might have just confirmed that you're on the right track with your management of suicide risk in veteran populations. Thank you very much. Good evening.